Well, we're going to wrap up the afternoon session with a Metabolomics case study. And although we structured this workshop around the idea that we were trying to understand the relationship between the exposome and the metabolome, it also became very clear that we were interested in the long run in understanding the relationship between exposure, the metabolome, and disease. And so this particular case study is one I think that we can consider good news. It's one that exemplifies the kind of data that one can glean from metabolomic studies and understand the relationship of exposures to the metabolomic changes that are associated with a particular disease. And so this particular case study is going to be presented this afternoon by David Wishart, and it's an interesting story. I think you'll find it informative, and hopefully it'll set us up for a good discussion tomorrow as we begin to think more about this relationship between the exposome and the metabolome. So, David?
Thanks very much. So I guess I'm going to be talking about something that's hard to pronounce, Eosinophilic Esophagitis, or EoE is what I'll call it. And we're going to use this, I guess, as a case study. So EoE, the name comes from the fact that you find eosinophils, which are white blood cells, in the esophagus. And it leads to, pictures here, both sort of a swelling around the throat, and then these purple cells, the eosinophils, invading much of the tissue. You get this sort of corrugated structure down the throat. The most obvious symptom is real difficulty swallowing, a constriction of the esophagus. You can get food impaction, heartburn. It affects adults as well as children. It affects males much more than women. It's a relatively poorly understood disease. We don't know what causes it necessarily, or where it came from, or why it's appearing. Although it is clear that there's some kind of food allergy, so in that respect there's some environmental component to it. With the way that it presents itself, and particularly with children, it's actually very difficult to diagnose, because in some cases, if they're just hard to swallow, then it could be any number of conditions. And so to actually fully diagnose it, they have to do lots of biopsies. And those are painful, especially for children, and most people don't like having probes stuck down your throat. So it's something that people would like to be able to distinguish from other diseases and come up with treatments. It manifests for children actually primarily as a failure to thrive. The children are small and stay small. Parents might notice that the kid is eating, chewing forever and ever, and they never finish what's on their plate, and then they bring their child in, and the doctor actually diagnoses it's not a psychological problem, but it's a physiological problem. What's also been noticed that many of the children and adults that develop EoE actually have other allergies, eczema, asthma, celiac disease. And I think these are important, just as I'll show you later, to remember. So there are different ways of treating it. Proton pump inhibitors, steroids can also work. A very simple elemental diet works, but the one that seems to be most effective is eliminating systematically different foods from the diet. The most common one that seems to help most is milk. If that doesn't work, they'll eliminate wheat. If that doesn't work, they eliminate eggs, they eliminate soy. And if you can hit, or at least by then, about 75% of the cases seem to respond. So again, this points to an environmental influence and relationship to some possible allergens with foods. Now, there's other things that are interesting about EoE. So the very first description of EoE was in 1978, and that was just an unusual case study. It wasn't until about mid-1990s where people started seeing a trend, like more than one person a decade. Now, the incidence is up to 53 per 100,000. So it's exploding almost at the same rate as, if you want, autism is. So a disease that was completely absent to one that's actually quite prevalent. As a food allergy, it's also very different. Probably a third of the people in this room may have some kind of mild food allergy, and most of them are mild. Some are extreme, like peanut allergies. But what's really unusual about this one is that it essentially leads to a near permanent inflammation. It's not something that if you back off the food for a little bit, things will respond. It's a case where there's a lot of drugs that have to be given, a lot of serious treatment, and in some cases it never resolves. So, as I said, it's exploding not only in the US, but many other countries as well. So that too is something unusual, because if you think of it, we've had milk, we've had wheat for forever, we've had eggs and soy. So what is it that's leading to this very, very rapid rise? Now, in many cases, people will point to things like autism and say it's just greater awareness. And that's been suggested as well here, but there was an interesting study in Denmark that was released actually just this past year, where they were doing retrospective biopsies and found that the incidence of biopsies was the same, yet the incidence of the disease had gone up 100-fold. So these are just some of the graphs in terms of the changes with EoE. Here's this Denmark study. So they've got the very restrictive definition. It's climbing by a factor of 10 or 20-fold. The relaxed definition or primary definition is climbing by about 30-fold. And then the really generous definition has gone up by a factor of 100 or more. Then on the right, or your right, is the US incidence from 2000 to 2007. It's gone up at least 10 or 12-fold. Prevalence, in addition to incidence, again, it's just shooting through the roof. This is in Olmsted County in Minnesota. So absent, 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 and then starts climbing in the mid-90s, then shoots up again. So this is, at least in the world of gastroenterology, it's an interesting condition, something that's clearly becoming prevalent. It's not and can't simply be a food allergy, because the complaining foods are obviously ones that we have been eating forever. So what is it that's actually leading to this? So if we look at the genetics of EoE, as I said, males have a higher propensity for this. And there's a number of other kinds of allergies, same thing with autism, where we see this male prevalence. There's similar kinds of issues with other diseases like asthma or others, where you have this unusual gender difference. Higher incident Caucasians. They've done twin studies already, identified a modest heritability, but the study was fairly clear that it's mostly environmental. There have been GWAS studies. Calpains have been identified or linked to it, Calpain genes. Thymic, stromal, lymphoprotein has also been associated with the condition. And then interleukins have also been found to be substantially overexpressed. So is there a genetic susceptibility? Potentially. In terms of the interleukins, maybe we're not seeing a cause, but more a consequence because of the eosinophilic infection. EoE and environment. As I said, I think we're seeing this rapid rise, which you don't see in a genetic disease. We're also seeing quite a bit of variation, too. And this, I think, is very important in epidemiology, is that you shouldn't just look at the US. You need to look at other countries and to see whether this is something that is prevalent or emerging in other countries. It seems to be. But even within states and counties in the US, there's considerable variation. So that makes it a little mysterious. We do know, as I said, prior allergies greatly increase the risk. We know that early exposure to wheat can increase risk. Interestingly, smoking reduces risk. Another one I think that, again, we'll revisit, H. pylori infection also reduces risk. And I think people have noticed a trend in terms of H. pylori over the last number of years with respect to antibiotics and stomach ulcers. Likewise, as related to this, early life exposure to antibiotics increases the risk by 6-fold for the disease. So again, this is about DOHAD and early exposure, or perhaps, versus late. Preterm birth, formula feeding, and I think we all know how that also affects gut microflora. Cesarean as well also affects the gut. And when I say gut, that stretches from the throat all the way down to the intestine. So these are, as I say, there's pieces of evidence that are suggestive, but it is, I say, it is a disease that's becoming more and more common, and in fact it's shifted away from being purely a childhood disease to one where it particularly strikes middle-aged men. So why is the condition increasing so quickly? What other environmental factors could be playing a role? What are some of the potential biomarkers that are possibly causing this? So we're looking at biomarkers of exposure, biomarkers of effect, and can we use metabolomics to help unravel some of the mystery for this disease? So I've been working with a couple of gastroenterologists I'll acknowledge them at the end, who brought this to us and who originally proposed this metabolomics question. But they were also interested in doing some epidemiological studies. So they had primarily children. Most were under, I think, 13 or 14, but a couple of older ones. 85 patients, but they also got a nice set of controls, in many cases siblings, roughly the same age. Same family. They all had very extensive questionnaires on life exposures, health conditions. And they also collected a lot of data on air pollution. So I come from Edmonton, which is the province of Alberta, which is one of the largest oil producers in the world. And it has, immediately around the city, a large number of refineries. And this has been an issue, one that they wanted to bring up. And so they wanted to go further than just the epidemiology and to do metal assessment using inductively coupled plasma mass spec, ICP-MS, and also to look at metabolomics of urine to look at markers of both effect and exposure that were organic molecules. This was done on a smaller cohort. So from their epidemiological study, they identified a couple of things which were sort of affirmed. So they saw the increased risk if you had eczema, increased risk if you had asthma, increased risk if you had an environmental allergy, but this rather significantly reduced risk if you had exposure in the first year of life, whereas exposure after seemed to increase risk. So that's the sort of thing that you can get. And I mean, the numbers are modestly significant. We're not getting 0.000, but they're trending. Said the food questionnaires, these are food frequency questionnaires, which are somewhat dubious, but can be useful. In most cases, none of the foods seem to be associated except for wheat, which was a novel finding, at least from this group. There have been other cohort studies where people have found some of the interesting relationships either to milk or wheat. We weren't able to reproduce this issue of milk, so that seems to be perhaps a little bit of a red herring, but who knows? As I said, Edmonton is surrounded by number of refineries and significant emitters. One area which is called Fort Saskatchewan has dozens of refineries, and they also tracked where these patients were. So, and where winds tend to blow in Alberta, it tends to be north to south. And so the green dots are the locations of the patients that were showing up. And again, these are children. So from there, they measured the location or distance from the emission sites to where the cohorts or children were developing these things. And basically, it's not really strong. Well, I guess 0.0101. EoE patients were much closer to these emitting sites, things that pump out a lot of air pollution and particulate matter. And in the case of oil and heavy oil, it's fairly rich in metals. This is just a map, again, of where the emitters are. And it's probably not clear from this one, so you'd have to know the city. But as I said, most of the refineries are in this quadrant of the city in Fort Saskatchewan. So this is how they mapped the location of emitters and distinguished between different types and different sources, some emitting primarily aluminum or preparing aluminum, other pulp and paper, other, in case of oil, there's also iron and steel. So those are all also mapped. Nothing particularly strong, just simply that there was greater proximity of EoE patients to air pollution. So that was the epidemiological work, and I think they weren't getting the big hit that they'd hoped, and so this is where they wanted to turn to my lab and to see if they could find something more about the exposures. They did do some studies on cotinine and nicotine, and that's also what helped to affirm and improve the measurements actually with smoking exposure. But we wanted to look at other things, primarily with urine, since that's much easier to get with kids. So as I said, we use inductively coupled plasma mass spec. This is a great tool, very sensitive tool for detecting metals, both endogenous as well as exogenous metals. And we collected, in this case, sure we should have had the numbers, but there was about, I think it was about 30 EoE and about 30 controls, and age matched, gender matched. And we saw rather striking differences, actually, with a number of heavy metals, both lead, manganese, and cadmium. These are in parts per million. Also, more modest differences in zinc, but also another very bizarre one, which we don't normally measure, was barium. In this case, where EoE is much, much higher. So that's quite striking, and then just using the data that we collected, we were able to use the principal component analysis and easily distinguish between the controls and the EoE patients in terms of the metals that were being dumped out into the urine. So in terms of, this is a surprise, we didn't expect that, and started doing a little bit of reading. Where do you get metals? Some cases it can be groundwater. Most cases, at least in Edmonton, the river is the primary source of water, so there wouldn't have been too much there. Food packaging and sweets, again, people have indicated this can be a source. Contaminated foods, tobacco, pharmaceutical products, in some cases, and herbal medicines seem to have sometimes high levels, cosmetics, and so other things. So this was just a collection of possible sources of multiple metals. There wasn't a single one, but several that seemed to be elevated. One of the other things that came out a couple of years ago was actually trying to look at the gene expression levels of patients with EoE. And one that was quite striking is that metallothionein in EoE patients is substantially reduced. So metallothionein is this metal binding protein, and it's the thing that'll grab a lot of the heavy metals, the toxic metals, and keeps them out of circulation. So you could imagine that if this thing is actually downregulated, then there's nothing holding on to the metals, and so they're going to dump out into the urine. There's also sometimes that we'll see other changes where you may see metallothionein overexpressed when you see other kinds of things with gasoline vapor, so short exposure. But I think this change, at least the reduction in metallothionein, might be something that's related to this rather substantial change in heavy metals. The other thing we wanted to look at, as I say, was the metabolomics, looking at organic molecules. And are there things in the food, things in the microbiome that might be evident, that could be leading to this condition? Are there endogenous metabolites that are perturbed, again, perhaps reflecting part of the condition? And part of the motivation for this was also to come up to see if we could get some nice biomarkers for the condition. Perhaps the metals would be as well, so that you wouldn't have to do the biopsies. So it's sort of a twofold thing. It's one, it helps the GI people to diagnose the condition without having to probe down a child's throat and cut things out. And two, it perhaps might give us some indication of the etiology of the condition. So in this case, we looked at, again, children, 30 EoEs, 25 age-matched healthy, and then 20 with a condition called GERD, which is often mistaken for EoE. GERD is much more common. It's basically heartburn, if you want, but it has similar symptoms. There is characteristic of damage to esophagus. And these are taken at first intake. So we're not dealing with looking at drugs and modifications, although it's not necessarily clear if someone are taking some off-the-shelf or over-the-counter drugs. We chose urine primarily because it was easy to get for kids, but urine concentrates a lot of things that essentially the body doesn't want. So it's a way of doing, if you want, sample prep, a quick sample prep to concentrate potential toxins or microbial metabolites. We use 3 different platforms, GCMS, LCMS, and NMR. I'll focus on the GCMS just because of the time limit here. And then we used a variety of informatics techniques, bioinformatics, multivariate statistics. We use the databases to help interpret them. So that's how we try and integrate informatics to understand things. So 30 EoE, had 20 lost on samples, so that's 20 GERD and 25 healthy. So in this case, 2-dimensional PLSDA plot, 3-dimensional PLSDA plot, there's reasonably good separation between the 3 or the 2 cases. This is healthy versus EoE. It's not perfect, so not as strong as certainly the metals. What you can do is look at the most important metabolites. This is called a VIP plot. And then we can also do permutation testing to see how significant the separation is. This is another statistical technique to assess things. So these are commonly used in metabolomics, and for some of you maybe this is your first time seeing these types of things, but these are fairly common techniques. And so what we can see is red is EoE, green is healthy on one side, left, right, and then green is low, red is high in terms of the indication. So we're seeing things like puric acid or methylsuccinate or deoxythreonate that are changed. In the case of EoE, they're high, and in the healthy, they're low. So these are quite significant in terms of how different they are and how they can distinguish between EoE and healthy. But then more importantly, at least from the physician point of view, can you distinguish EoE from GERD, which symptomatically are very, very similar. And in fact, the distinction is even stronger, which was good, which then makes this concept of a urine test for EoE potentially very feasible. And again, we get a collection of things. This is a VIP plot, high level of significance. In the case of EoE, we see a number of compounds that are dropping, whereas in GERD, they're much higher. So we've developed ROC curves, analyzing the sensitivity and specificity from the GCMS work. And this is the sort of thing that you want to do or evaluate whether you've got a useful or informative kind of biomarker. And areas under the curve of around 90% or more are usually a good sign. That's what you'd like to have in terms of identifying a set of biomarkers. But obviously, in terms of understanding the etiology, you'd like to know more about the compounds. And so the ones that were most effective in generating the best quality biomarkers were the ones listed down at the bottom here. So there's not an overlap, but in some respects, we're looking at 2 different pairings, EoE versus GERD, EoE versus healthy. So what do these metabolites mean? Well, to do that, we had to start looking through A, the literature, B, the databases, to see if we could better understand why we're seeing these changes. So one of the things, as we quickly learned, was that many of the metabolites that were distinguishing between these conditions, both EoE and healthy and EoE versus GERD, were actually of bacterial origin. And that seems to support some of the other information in terms of, again, people are finding a microbial origin to things like eczema, to asthma. They're finding a strong microbial origin to a number of other autoimmune conditions. And then this linkage between H. pylori and this linkage between this early exposure in life to antibiotics leading to a 6-fold increase in EoE. So I think this also suggests that there is a substantial perturbation to the gut microflora to EoE patients. And when I say gut, I'm talking mostly the microflora in the esophagus. We saw some other compounds, which, again, it's hard to know, so these are associations. So acetaminophen, which might be given to these kids, we did see high levels or altered levels of pyroglutamate. And then we saw this other 2-hydroxy-2-methylbutyric acid perturbed. And it's potentially an endogenous metabolite, but it's also a gasoline additive that is converted to this hydroxy derivative. So what it's doing there, we don't know. As I say, it could also be a microbial metabolite. So not enough is known. But I think, a couple of things that came out of this. One is it suggests, reaffirms, I guess, this idea that microbes play a role. It also suggests that we can use metabolomics, a urine test, a very simple one, to distinguish EoE patients from GERD, which is hard, and also diagnose EoE patients without having to do the biopsy. As I said, we also used NMR, we also used LCMS. I don't have enough time to go into these, but it was fairly comprehensive. Similar kinds of findings were reiterated in both studies. So in terms of EoE, in terms of the overall interpretation, if you plot the rise of EoE and you plot the rise of the incidence of asthma, the rise in incidence of colitis, and more particularly the rise of Barrett's esophagus, they match very, very closely. And as more and more is being published, have very strong associations with early exposure to antibiotics, to certain types of drugs. They obviously have links to foods and pollutants. They do have a minor genetic susceptibility component, but really the message that seems to be coming out more and more is that what you were exposed to early on fundamentally alters your microbiome, which then fundamentally leads to the disease. So EoE manifests as an allergic condition, but it appears to be really brought on by an altered microbiome, which was ultimately due to modern environmental exposures. So I think this is an example, as say, a useful case study where we've combined epidemiology. So we used classic questionnaires and associations. We've used some GPS pollution analysis. We looked at metal exposure analysis, which potentially explains this modification in the metallothionein, which was a puzzle. And then we've shown how multi-platform metabolomics and bioinformatics and literature associations and understanding the origins of metabolites, which I think is also very important, to learn more about the etiology of this sort of mysterious disease. There's certainly some unexpected results. We never expected the metal stuff to reveal anything. The microbial one was kind of nice to see, but again, we wouldn't have known. This is not published. We're doing some validation work now. I think even if we haven't got a perfect understanding of the etiology, I think our GI partners are very happy because I think they feel that they've got now a very simple method to start doing some rapid diagnosis of EoE. And as I said, as with any kind of study, it always needs to be further validated with different populations in a larger cohort. I'd like to thank the people who actually worked with us, Mordecai Slay and Hien Huynh, who are the two gastroenterologists who worked with us, and then others in my lab and across who've helped collect some of the other data and analyze what I've just presented. So with that, I'll thank you very much.